Good morning. So this is an interesting problem. I think the reason I picked this problem is to see whether we need to see and review an interesting paper that came out in Gastro that will have impact on the way we manage patients. So this is a gentleman in his 60s, and he was referred for endoscopic mucosal resection. And what happened was he went for his first screening colonoscopy, and a polyp was found, 2 centimeter polyp in the ascending colon. And the endoscopist raised it with LVU and then resected it partially with a snare. And you can see the image there, but I will go through that in a little more detail. And the pathology was tubular adenoma with intramucosal cancer. All right, so that's the background. And so for those of you, if you want to get the CME, we have an option now. And I want to thank all the panelists. And so let me take you through this story. And I also want to acknowledge the support of my mentor, John Stoline, Mr. Charles Butt, Angela Dale in my institution. So we actually reviewed this case, basically 2 centimeter polyp, partially resected, otherwise in good health. And this is what you get actually when you, with this patient. I actually tried to take this photograph with my cell phone and try to get a much better. This is the max. This is what I saw when I received the patient's information. And the lesion is here. It's not a big lesion. It's about maybe 2 centimeters, right? And this is the LVU injection, and then the partial cut. And you can see the partial cut was in the center. And the pathology was intramucosal cancer, not intramural cancer. So just wanted to share this picture again. Here is the mucosa, epithelium, lamina propria, and muscularis mucosa. Anything limited to the epithelium is either low or high grade dysplasia. But when it involves the lamina propria, then you're thinking about intramucosal cancer. And when it goes beyond the muscularis mucosa, then it's invasive cancer. So we know that, but for the sake of trainees, I wanted to review this. Okay. So we have Zubair. Actually, Zubair is one of our fellows at UT Houston, one of my favorites. So I asked Zubair to take us through this thing, all right? Zubair, you're going to comment, and you have the best teachers here who can help you. So what do you see? Why don't you take us through what you see?
So I see a lesion like at 9 o'clock.
Okay.
And it's like polypoidal, like it looks like a little bit. It seems to be some like looks like to be neovascularization because there is some bleeding that is evident on the surface as well.
Mm-hmm. Okay. All right. Anything else you see?
Apart from that.
Okay, let me play this one again. All right. So that's one. Okay, I'm going to give you a little more help here. And I'll put the narrowband imaging to help you. All right. So what do you see?
Okay, so now I see actually beyond that. I think this is the one that is partially resected, and then beyond that, in the next fold, there is sessile polyp with the mucus cap.
Okay, that's reasonable. So I'm going to go back, just for the sake of, now you see something, right?
Yeah.
You see the lesion here and you see this one. Yeah.
Yes.
It's interesting, actually, the endoscopist who sent us the case has not mentioned about this other lesion, but just for the sake of our own learning, when you're watching it, you want to watch, and we all get drawn into something that draws our attention, but there might be something else, right? And why don't I let, so there are two lesions, right? And why don't I let our panelists to comment? Maybe start with Sylvia and then Roy, and anyone else who wants to comment on this. So.
Yes, I think this is a very interesting case. I would notice there are two lesions in the same segment, but I would not hesitate to focus on the most important lesion, first things first, because sometimes we have to make choices to avoid cognitive overwhelming, as Roy suggested us. So the lesion which is proximally located will not be my first, the lesion which I would firstly characterize. I would focus on this lesion, and I would apply the ACE algorithm. So appearance, in my opinion, there is fold convergence in this case. So I see that the folds are converging towards the lesion, and the lesion has a central arc, not only friability and redness, as I have initially thought. I think there is superficial ulceration. So altogether, these signs are pointing towards high risk for deep submucosal invasion. And the second step would be to classify the lesion. So this is a small lesion. I think it's less than 2 centimeters in size. It's less than 1 quadrant in diameter. And if we look to the Paris classification subtype, this would be, in my opinion, a 2A to C lesion. And most important step is enhanced endoscopy, which confirms actually the diagnosis and shows a central area with no structure, so amorphous sign, or no structural area. So in my opinion, this is a lesion with high risk of submucosal invasion. So I would be very careful in management of this lesion. Do I have to classify the second one, or shall we focus on this lesion?
Right. So let me ask you this thing, the patient had an EMR where the central portion was removed after a LVU injection. How much of it is actually what you're seeing following the resection or of a benign lesion, or is it a tumor? And how do we differentiate that?
I think that, at least in my opinion, this lesion is suspect for deep submucosal invasion because of the features I have already mentioned, the converging folds and the ulceration. And I would, it's a small lesion. I would still prefer to resect it on block by ESD if available.
All right, Roy, what are your thoughts?
Well, let me go back a little bit so that people can see like why we need to do this systematically. So forget about looking at a lesion inside the colon. When you see a patient in the clinic, the first thing you do is not to put a stethoscope on their chest. The first thing you do is that you look at the appearance of the patient. Is the patient well groomed, for example? Is the patient having cold, clammy hand? Are they appear to be very sick? So the first thing is like a general appearance. Before then, you can come closer and trying to get more history and interrogate the patient, so to speak, and then have a mental representation. Oh, this patient actually coming in here because of a potential diagnosis of I don't know. You can say new onset diabetes, for example, and then you start finding evidence that support your diagnosis. This deductive reasoning we learn from basically day one of medical school. I don't know what changed in endoscopy that people nowadays just say, okay, the first thing I need to do is I turn on the NBI. That's like you see a patient in the clinic and then you say, sir, the first thing I do is I put a stethoscope on your lungs or on your chest. It really doesn't make sense. And what we need to do is really to follow the same way of thinking. So the first thing when you look at this lesion, and maybe Raju can go back to the white light. And I don't really care whether this has been cut by so-called EMR or not, because it looks like the lesion has not been cut. It looks like a native lesion. The first thing you see is that, oh wow, I look at there's a patient coming in from coming in. I see it from far away, and there are these like folds that are coming together toward the lesion. On the top part coming in, there are at least two folds. At the bottom part, there are like more than two folds, maybe three folds. And that area seems to be like contracted. And then I look at this triangular structure of the lumen, and I say, holy moly, there is a part that's missing. It's like somebody had bitten, had took out a small piece of that area there. And then I come close to the lesion, and I say, wow, there is this area that looks friable. And that area, that's where the friability is actually missing a part of the tissue. Maybe Raju can move forward to come closer. So when you see an area that's missing, especially the obvious one that's missing, usually that means there is a depressed lesion. Depression can be most appreciated when you spray indigo carmine. And now from this angle, stop there. From this angle, you can actually see the depression. There is like a part that's missing. But more important, there is like this, there's an ulceration at, I don't know, it's like, Raju can point it right there. So an ulceration is not part of a superficial lesion. Okay, when you see an ulceration, that is not a superficial lesions. So this is really a depressed lesion that has degenerated to become an ulcerated lesion with all of these other findings that suggest that this is deeply submucosal, if not an advanced cancer. So that's the first step. And then you try to do the second part, which is like what Sofia says, is that how do I classify this? Well, if you really believe that there is an ulceration, ulceration is not part of the superficial lesions. Ulceration is a deep lesion or an advanced lesion. And the classification really doesn't matter here. Now you're already going into the cancer, the advanced cancer area. And you can say, well, this is a depressed lesion with an ulceration. And then you do the NBI, which is the stir sub. This is when you put your stethoscope on the patient. Then you say, aha, I confirm, sir, you have a murmur. Here you say, sir, I confirm, meaning sir, meaning polyp, I confirm that you have an area that has no pattern. An area that has no pattern inside the ulceration or in the depressed area means that there is a type 3 nice classification, which is to say that this is an advanced is an amorphous, meaning that this is a cancerous lesion. And we are done. The part here that I often do is that I would spray indigo carmine just to understand more what depression looks like, and done. The other lesion is just a red herring. That's just like an SSA that has no significance in the setting of a cancer.
Beautifully done. All right. So what do you do next? One is we can spray, but at the same time, what I thought was let's make sure that this doesn't lift, to document that this is something that we could not cut. And maybe Sriram or Ravi or Joseph could comment on the lifting.
So far, not lifting too well. The periphery is lifting, but not the actual lesion.
Right, right. So one thing is, when we are thinking about lifting, whenever we inject, you think that's the top of the dome. And then on either side, here the lifting has happened away from the polyp. But actually, if it is truly lifting, the polyp should also have lifted about the same height, right? You don't see that, And the second thing is, you notice this when there is tumor infiltrating the submucosa, as you inject, the solution tends to backfire. You see that? So something to keep in mind.
I think the one more thing which I wanted to see is like comparing this submucosal injection where we don't see a lift. The initial few endoscopy images that you shared from the previous, the first procedure, actually two things which you can observe is even with L-view, the lesion did not lift well. And secondly, you can appreciate the depression which Roy was mentioning in the second image. So the reason why the first endoscopists had trouble resecting this lesion is because the lesion at the center never lifted properly. Basically, they just shaved the superficial aspect. So I think from the beginning, there is a depression that can be appreciated in the second image, and then the lesion is already not lifting.
Here, right? That's where you're talking about. You see the arrow? In the second image, I'm pointing with an arrow, right? Yeah, that's a good point. I'm glad that you brought it up. Yeah.
Ravi, the reason why the first endoscopist could not resect it is actually deeper than what we presented here. The reason why the lesion could not be resected is that the lesion was classified wrongly. He tried to cut an advanced or a deep submucosal cancer. That is like saying, "Oh, sir, you have a murmur, and let me just give you aspirin," or something like that. It's like the diagnosis is wrong. So this lesion should not have been attempted to be resected.
Agreed.
So one of the things for the sake of fellows here is when you see a lesion, like here, image 2, that's the best image that we have, and then we have an image here where failed resection. One should take time and really document the lesion from a long shot, a medium shot, and a close-up shot to really define the actual appearance. That would help us figure out whether it is, first of all, a polyp or not. Is it benign or not? And if it is cancer, cancer or not. I think having those detailed pictures makes a big difference. Taking one shot and then going at it, sometimes we may not be able to do the right thing.
Raju?
Yeah, please, Selvi.
So I think it's a very interesting case, many different aspects that we can learn from. My question to you is, would you maybe share with us what you spoke to the patient about, how you counseled him before you brought him in for colonoscopy? Because you had these records and you knew what kind of a lesion, you had the pathology.
Right.
What were some of the things that you talked to the patient about?
Right. So
in terms of your ability to resect it?
Right. I think one of the things is I tell people whenever I see somebody for endoscopic mucosal resection and I don't have clear images, one thing is important to share with the patient is, you may be fooled by just the picture because you don't have the actual dynamic view of the entire lesion to make an assessment. And I've also told them that I've been fooled many times where I thought that I could take care of the problem with endoscopy, but actually what happened was the lesion was much larger than what it was. Sometimes a lesion that you think you could cut in half an hour, just a couple of weeks back, it ended up being a 2.5 hour cut because the person who took the picture took one picture, didn't describe it well, like Sylvia commented on, how much of circumference or whatever he just said, 2 centimeter or 3 centimeter polyp, but didn't define it. The second one is when you see intramucosal cancer, you wonder whether it is actual intramucosal cancer or something else. It's also important to appreciate that patients, when they're presented with intramucosal cancer and they are not told that, hey, you have definite cancer, they always want to see if there is an endoscopic option. And that's the reason why they want to go ahead with another exam to see if it is something that can be cut. So I tell them that whenever I see a lesion like this, I tell them that if I can lift, then I can cut. And I tell them that if you can lift the lesion well, the chances that that lesion is cancer is very, very small. And even if it is, it tends to be in the superficial submucosa. Lesions that don't lift are the ones that have desmoplastic reaction going deep into the submucosa. And in that case, you can't lift and then you need surgery. So that's what I usually present to the patient. So I tell them that I'll look at it, I'll decide whether the lesion is cancer or not, and then I'll also inject to make sure that it lifts or not. If it lifts, we cut. If it doesn't lift, then we basically do the marking to help the surgeon and clear the rest of the colon. So that's what I present. Yeah. Let me ask what others would do whenever they see a lesion like this. Let's start with maybe Sriram and then Ravi, Sylvia and Roy to see what they would do.
Maybe he's muted.
Yeah, why don't you, what would you say, Roy? Why don't you say that?
What I would do is, I missed like the first 2 minutes of this presentation, so I don't know whether they had tattooed it or not. And this is probably in the right colon. Sometimes if it's in the transverse colon, I put a clip because the surgeon needs to know whether it is in the proximal transverse or is it in the distal transverse. The management of proximal and distal transverse in terms of how they approach it with laparoscopic surgery is different. So you need to give them a method that they can do an abdominal X-ray, and they can tell, oh, okay, this is a proximal transverse. My ports needs to be like this, or distal transverse when it is at the splenic area, it would be different. But really, in here, you have to take a couple of biopsies. And really, what you want to do is you want to biopsy at the amorphous area. So in here, it would be in the ulcerated area. That would be a good target. Do a couple of biopsies to confirm that it is at least has a dysplasia. But the honest truth is that whether there's a biopsy or not biopsy, this is a neoplasm, and it cannot be cut endoscopically.
Yeah.
So this will need to be removed by surgery.
So the patient would need a CT scan, I would argue,
Yeah.
chest, abdomen, pelvis with contrast, basic lab, serum CEA. And then in our institution, that's how we triage. Based on those studies, patient either goes to medical oncology or surgical oncology.
All right. So we took biopsies. I think one of the things is like Roy pointed out, we're taking biopsies from the area that where we think we're going to have a diagnosis. And I think one of the things is very important for us to keep in mind for the sake of fellows is patients do not want to go to, patients want to go to surgery if you could prove that this is cancer and you have a pathologic diagnosis, then it is much easier to convince them, hey, we have a problem, this is cancer. The only way to fix this is by surgery. And they are much more likely to follow your advice. On the other hand, whenever it is, you take a biopsy and you have not taken time to read the lesion and take the biopsy from the cancerous area, and that is the amorphous area on NBI, then you miss the diagnosis and you may get either high-grade dysplasia or intramucosal cancer. And then you are stuck and a patient may say, hey, is there any other option, especially if you don't have convincing imaging to convince yourself and anybody, any other endoscopist that this is truly cancer, then you're stuck. So important to take biopsies. On the other hand, it's also important to read the lesion. And if you think it is benign and doesn't have any features of cancer, then don't biopsy like crazy. If you want to biopsy just to say, okay, this is benign, it's not cancer for sure, I just want to tell the patient it's benign, then take a biopsy from the edge rather than in the center. The reason I say that is just last week, I had a patient that came in. It was a 2-centimeter lesion. 2-centimeter lesion is not difficult to cut. It was a laterally spreading granular tumor. But when I looked at the pictures from the referring endoscopist, the whole center was bloody. Multiple biopsies were taken. And although it lifted, basically when you put the snare, it folds itself in the center where it is tethered. And it took almost 2 or 3 cuts to clear the periphery, and multiple hot biopsy avulsions bit by bit to remove the central tethered area. So it's important, like Roy commented, to figure out what the lesion is, and based on that lesion, if it is convincingly cancer, then you can document with biopsies to make sure it is cancer. And you don't have to take multiple biopsies. You can figure out where the mucosal vascular pit pattern suggests cancer, and you take one biopsy, you should be able to get the diagnosis.
Raju,
Yeah.
there's a question in the chat from Evangelist Russo, and they're wondering whether there's an option for endoscopic full thickness resection in this patient since he's a poor surgical candidate. Can you comment on that?
So this is a lesion that is too big for endoscopic mucosal resection. I think this is more than 2 centimeters. The second thing is you have to keep in mind when you're thinking about endoscopic full thickness resection, whether you can get the whole thing in one piece. That's what I think. Let me ask the rest of the group to comment on that. Maybe others could comment on full thickness resection in this case. I personally think that this is not suitable for full thickness resection. And you also need to keep in mind when a lesion doesn't lift beyond the, that means your submucosa is plastered. And if you think about the, let me go back actually. Okay, so as you can see here, this is SM1, that is submucosal cancer limited to the upper 1/3, SM2, that is to the middle third, and SM3 deeper, and then T2, right? And whenever it goes beyond 2 or 3, you have a very high chance of lymph node involvement. And as part of your surgery, as part of your treatment plan, the reason for surgery is not only to remove the tumor, but also to clear the lymph nodes. So when you see a lesion that doesn't lift at all, and you think it is from the tumor infiltrating the submucosa, it's probably best to go for surgery. In this gentleman, he didn't have any serious cardiopulmonary issues to put him at high risk for surgery. And you can actually plot somebody's risk for surgery by looking at various comorbid conditions and present that plan to the patient. So let me leave it here and want to hear others' thoughts on this full thickness resection of this patient.
I completely agree with you. Just because we can do it doesn't mean that we should do it. There is a high risk for lymph node metastasis in here. And just because we can possibly wiggle it and cut it endoscopically, it doesn't mean that it's something that should be done. I would not do it. I think this is very high risk for lymph node metastasis. The risk is probably more than 15%.
Right.
There are two aspects in this, right? One is even if we indulge in for full thickness, to make a case for it, it has to be the patient's condition should be so morbid that he cannot undergo surgery. His risks cannot be optimized for allowing him to have a surgery. If just for argument's sake, if the patient is so morbid, such comorbids, then you are talking about what is the survival of this patient from this point onwards because of his comorbidities versus if this is a colon cancer, what would be his 5-year survival? And in that sense, the colon cancer is relatively slow progressing for a morbid case, in which case he will be out before the lesion can take him out. So that is another reason why we do not consider, we have to keep in mind about any local resection versus surgery, possibilities for surgery. Coming to this patient, I think patient has let us not forget the other larger lesion, which is more towards the cecal side of the colon. And in that sense, even if you take care of this lesion, that even when we consider this has a submucosal invasion, the other lesion will also need to be removed, which means a right hemicolectomy is in his fate one way or the other. Now, coming back to I fully agree. I'm sorry I missed before due to microphone problems, but I fully agree with all the conversations we had before. I have two pet peeves about this kind of situation. One is planning a line of attack before we actually pounce on the ball, which means that I need to know what is the best position for endotherapy and whether the lesion will lift or not. And that is where I have personal reservations about any of these lifting agents. And my go-to lifting agent is saline. My rationale is that if it doesn't lift, I have not done any major damage. If the patient can go for an ESD, the saline lift is going to disappear and there will be some adhesions, but at least it will not be as worse as using a lifting agent for that purpose and causing submucosal further adhesions and fibrosis and difficulties for ESD. My belief is that the saline related injection related fibrosis will be less than the lifting agent related fibrosis for ESD, but I have no personal experience on that. And so if one is hell-bent on using a lifting agent, my choice would be first use saline, see how the lifting is happening. Once I'm happy that it will lift, then use the lifting agent so that I can proceed with the next steps. If it is not lifting with saline, there is absolutely no reason why to complicate matters further, because if it doesn't lift with saline, it is not going to lift with a lifting agent. Lifting agent purpose is to retain it for longer duration, not to facilitate lifting by the mechanics of using the volume in that space. And coming back to the original lesion, that was a very good observation on I think Dr. Ravi's part about the appearance of the lesion itself. It starts with it as a depressed ulcerated lesion, which will be a difficult lesion for endotherapy. So it required further defining of the lesion rather than pouncing on it for a polypectomy right away. And that would have given a little more breathing space to reassess and then regroup to see if this is actually a lesion that can be safely removed endoscopically. The other point I have is that when we look at the lesion like this, my preferential initial injection would be on the oral side or a cecal side of this lesion, because it is spreading over a fold I would also like to know if it is lifting out on the other side or not, because I'm not completely seeing the other side. And rest of the conversation is I agree with all of it.
All right. So thank you, Sriram. Thank you, Ravi. Roy, thank you. So now that you have the lesion you biopsied, you think is cancer, what would you do next? You put a tattoo, you put a clip, and as you come down, you see some more polyps. How do you deal with them?
I would clear all the polyps below the level of hepatic flexure, if they are technically doable, so that patient can go for a safe right hemicolectomy.
Roy, what would you do?
I completely agree.
Okay. Sylvia?
I have a question for Sriram though. Is there a study that proved that the lifting agent other than saline causes submucosal fibrosis? Has that been reported? I suspect it does. I agree with you, but I just wonder if there's documentation.
No, I'm not aware. I'm not aware of it. Whether I mentioned that, but it also makes sense, right? There is any additional substance other than saline, probably, because even if we dilute it with methylene blue, we have the evidence that it causes some fibrosis. But I do not know the study.
Okay.
I can share a personal experience of at least few cases in this kind of situation where I'm not sure it causes much fibrosis. And the reason is, I work in two centers. One is an ambulatory surgical center and the other one is a hospital. And sometimes to avoid patient coming back for another procedure, I try to, take out a 2 centimeter polyp, sometimes an ambulatory surgical center as well, or a bigger polyp. And I have injected it. And then when you inject, sometimes things become even bigger. And sometimes, you don't have the right accessory to take it out. And so you say, sorry, I have to abort this today. And I don't want to start cutting because I know after cutting, there will be definitely fibrosis. So then you bring the patient back in 6 weeks, 8 weeks in the hospital setting and anesthesia and all those things. And, and then you try to cut the same polyp and you're a little bit concerned that, I injected, I'm not sure how this is going to go. But so far, 2 or 3 cases that I've seen like this, I didn't encounter much fibrosis, and those were injected either with Aliview, Orize, and then recently with the Everlift. And this is over a span of 3 years that I've seen, from just N of 3, but from personal experience, and also some cases that were referred like this to me from where other people had injected and had second thoughts about it and saw more than what they initially saw. And then they aborted the resection. They just took a small biopsy maybe on the edge, and then they referred the patient to me. So from those anecdotal cases, I didn't see much fibrosis or encounter much problem.
That is somewhat reassuring. That's a good observation. I would still tend to believe that initial saline injection followed by a lifting agent may be still a better way to go forward and no damage done, if at all it helps. But I appreciate Aman's comment.
I think there are some reports with regards to Orize gel causing giant cell reactions and amyloid-like deposits in the EMR specimens. So probably it's true that these submucosal agents to a certain extent cause some degree of inflammation and fibrosis. Because if you look at some of the histological assessment papers, they say that there's a lot of eosinophilic reaction secondary to these injection agents, especially Orize.
All right. So we put a tattoo here, I think, and then we cleared some of the polyps. And as we there was a couple that required a cold snare and another one that required a biopsy. So, and the reason I asked this question about, what do you do when you see a cancer in the colon? at least I was taught, and like me, most of you, we all practice the same protocol. That is, we biopsy and then the cancer, and then we tattoo the site of the cancer, and then we try to remove the colon polyps, whatever are remaining, so that the patient can go for a resection. So as part of that, I was actually wanted to share with you something very interesting. That is this study that came out just towards the end of last year. This is tumor seeding during colonoscopy as a possible cause for metachronous colorectal cancer. Came from Netherlands, from Sylvia's place. And there was a beautiful editorial by James East from Oxford, Zubair. And if there are any other fellows, I strongly recommend that you read that article. It's a beautifully written article with beautiful illustrations. And what they've shared is, what the study showed was that they looked at a bunch of cases in Netherlands, I think a large hospital system, and looked at cancers that developed after resection of a colorectal cancer. And I think they identified about 5 cases where there was a metachronous colorectal cancer, interval cancer, I think within 5 years. And they looked at the genomic profile of the original cancer and the genomic profile of the metachronous cancer. And they had a complete match, right? Normally, if it is a different cancer, usually there's no match. The fact that they had a match, they feel that maybe this is a tumor seeding. And then they did another study. They had to prove it in a circular way, going around. So then they took colonoscopy. They took biopsies from colon cancer, and then they took the scope out, and then flushed it with saline, collected the fluid coming out of the channel for cytology to look for cancer cells. And then they also tried to see if those cells could grow into organoids. And they've shown that they have demonstrated that the channel was positive for cancer cells. The third thing is they have done is they took biopsies, came out, and then they pushed a needle through the injection needle through the same channel, and then washed the needle and found that there were some cancer cells, right? So what they've come up with a suggestion is that like the surgeons have tumor seeding after gallbladder surgery at the port, abdominal port, or the head and neck cancer patients developing PEG site seeding. A similar mechanism could play a role for metachronous colorectal cancer. But it is extremely rare. If they came up with a calculation, it's 0.5% of the cases, or 0.5 to, it's less than 1%. And so they wanted to keep this thing in mind. And they, in this editorial from Dr. East, James East from Oxford, he came up with a beautiful editorial, and he said, maybe if this is what is happening is this mechanism is possible. One way we can get over the problem is normally we biopsy the cancer and then the tattoo the area and then clear the colon, right? I asked you, you all said that's what you do, that's what I do. That's what I was told or taught for years. And James suggested that it's better to clear the polyps before you go and do anything with the cancer. And Put a tattoo first before you biopsy the cancer. So these are the suggestions. And he also suggested that if you need to, if you biopsy the cancer and you need to take some more polyps, he went on and suggested that maybe you need to change the scope. So why don't I actually leave things here and ask the thought process, thoughts about this paper, and see how do we do this in our own practice. Sylvia?
I think that the tumor seeding concept is an old concept. As you have mentioned, the surgeons are describing, especially laparoscopic surgeons are describing contamination with tumor cells of the surgical site. And we know that when placing a percutaneous endoscopic gastroscopy in a patient with an oropharyngeal tumor, there is a risk of tumor seeding and implants at the site of the PEG. So this is a well-known concept, but indeed there are just very limited data about colorectal cancer. And because we see more and more patients with screening, and I think it is good to include these observations in our protocols. So it's actually, it needs a confirmation definitely, but awareness I think is very important.
Yeah, actually, it's a beautiful paper, don't you think? They have done a really good work, although it's a very limited initial observation.
It's a very important observation.
Right. Roy?
You want me to tell you honestly what I think?
You can tell me. This is an open session, so. That's why I
I
wanted
think
Sylvia to comment first and then came to you.
I think this suggestion is constipated. We know that we could certainly implant cancers when we pull tissues onto injured area, and but then we should also think that the amount of exposure, meaning like, when the surgeon pull colon cancer through the port, or we do it on gastrostomy, it is like a lot of tissue, a lot of cancer being exposed to the injured area. Now, having said that, if you biopsy a cancer and then you don't, and then you use the same biopsy forceps onto another area, you certainly could implant that. That is not like rocket science. Many of us know it, and actually maybe we just don't write about it. But for a fact, we never use the same biopsy forceps. So we
So
use a
repeat that.
biopsy
You don't
forceps
use
on
the same.
cancer, right?
You biopsy
I
the
throw it
cancer
away.
and then take another biopsy for other polyps. Is that right?
Yeah, they use the same biopsy forceps. That's like you're not thinking that you're doing that. So we throw away the biopsy forceps if we have to biopsy another side. But then if we don't we follow these, right? We have, like, for example, we have this cancer on the right side, and then we're going to change the colonoscope. The colonoscope is going to go through, I don't know what you suction and all this. Is really like, yeah, great, we can do this in Oxford and all this, but this is really not proven. If you really want to, and this is what many of us, I think, do, is that first biopsy, use biopsy forceps that's dirty, we don't use. And then if we think that there is like tissue in the channel, then we wash the channel. And if we need to snare something else, then we do it that way. The part why I'm saying that you may have to remove another lesion is that if you tell the surgeon, we have a cancer, we also have a 2 centimeter lesion in the transverse colon, but we cannot remove it. We follow this Oxford paper and whatever. And the surgeons will say, excuse me, I have a hard time just cutting the right colon. What if you then find that this other lesion has cancer in it? Then I have to go back and then cut the rest of the transverse colon. They're going to go crazy. We need to also remember that 14 million colonoscopies are performed in the US alone per year. And we don't see these exquisite cases that are beautified in gastroenterology. It's rare. It's like when people are not thinking doing their procedure, then we get into trouble. That's my honest opinion.
All right,
I have a quick comment.
go ahead.
So I agree with Roy's sentiment, but just to give the benefit of doubt to to the guys who did the study, but I do have a little bit of a concern for removing proximal lesions. When you say, for example, you have a cancer in the left colon and you're able to negotiate and go forward and have a lesion in the right side. I would tend to be more careful not to do a piecemeal resection of polyps in the proximal to the proximal colon if you have a distal cancer, because if there is any possibility for contamination of the specimen with piecemeal resection and collecting all that material, and then you see some cancer cells here and there, and it becomes very difficult for pathologists to give you a clear-cut answer as to whether this is coming from here or there. On the other hand, if it is a de novo single piece resection, if there is any superficial contamination, most of the times pathologists will be able to tell if there is if there are free floating cancer cells on the surface versus there is any invasion. So that kind of a pathological clarification is possible if it is a single piece resection versus a piecemeal resection of collecting a bunch of tissue. That is the only concern I would take, if at all, from this. But it is also common sense. It doesn't need this study, not to belittle the study. It is beautifully done for whatever it's worth.
I loved what you just said, Surinam. It's like we need to use some caution and common sense, but then we cannot use the caution and common sense to go and swing the pendulum and to go to the other side and say, oh, you can change the colonoscope first, or you do this and you do that. Well, if you you change the colonoscope and do all of these things and still don't use your common sense, then I don't know what helped you.
No, I agree. Just because you change a colonoscope, you can still take the cells through when you are negotiating through the tumor to go to the proximally. You can still take the cells with you. So I agree with your point.
Yeah, I think we have a very short time in this meeting, but I would urge everyone to really try to teach others or share with others. For the fellows to think it like, when you approach a problem, you need to do it systematically. So the first thing that you need to do is to understand the appearance. What does it mean with these things? And then you try to fit it into a mental representation of what is the disease process that this thing fits into. And then the last thing is you confirm the diagnosis. So unfortunately, the MSDF itself could not figure it out. So then we need to point it out in a letter that I had shared in the chat. It is still a letter, but I hope that many of you will look at the systematic approach so that we don't get into trouble like in this case, whereby there is no diagnostic process, and then the person just say, I'm going to cut this. Cut what? You're going to cut cancer? No, it cannot be done endoscopically.
So I put in a couple of articles in the chat for the lifting agent related stuff.
Thank you.
All right. At least one thing is, in addition to having a systematic approach to a lesion, going through the steps, when you see a cancer, I think it's reasonable to at least change your biopsy process before you take your next one. Is that a reasonable thing to do? What do you guys think?
I completely agree. I would even wash the channel with a copious amount of fluids and things like that.
Right.
We really need to, like be very cautious and,
Right. Okay. All right. All right. So first of all, I want to thank everybody. Thank Roy, Selvi, Sylvia, Ravi, Sriram, and Aman, and everybody else who joined. I really appreciate it. I just wanted to share with you, I'm on hospital service next weekend. I'm sorry, we didn't have it last week. And next week, it's very hard for me on the hospital service to do this. So we will meet the week after. All right. Take care. Bye-bye. Thank you.
thank you.
Thanks, everyone. Take care.
Take care.
Bye-bye.
Thanks a lot.
Bye.